Hello, everyone. Good afternoon. Thank you for being here to one of the last sessions of today. We are Giacomo Grasselli and Ricard Ferrer. We are going to present you a case of infection in ECMO, and we are going to discuss with you. So it's supposed to be very interactive. Please interrupt any moment because we need your feedback. You need your interest to develop the case and to discuss any point.
Yeah, so there's a microphone there, so if you need to ask the questions, please do it on the microphone because the session is registered. And I think that we can start.
Yeah,
so
we can start.
Let me see. Sorry. How does it go back? So these are our conflicts of interest, Ricard and mine. So this is the case. It's a real case that happened to our unit. So you can see there a 56-year-old man, slightly overweight, only with a history of hypertension, and he had fever, fatigue. He was given clarithromycin by the general practitioner, but then he was admitted to a peripheral hospital for acute respiratory failure. He was intubated. And this is the diagnosis is influenza A. So actually, they started anyway a broad spectrum antibiotics with piptazo and levofloxa. And they started him on oseltamivir and for unknown reasons on methylprednisolone, or maybe unknown. At least I don't understand them, but maybe we can discuss if you want. So this is supposed to be the CT scan that was. Okay. That, as you can see, is consistent with ARDS, secondary to influenza A, and you can see there the respiratory mechanics parameters. So basically, low compliance, 32. Still, let's say, reasonably protective ventilation with 14 centimeters of water of drain pressure, but severe, as you can see there, severe hypoxemia, 55 of PaO2 and respiratory acidosis, and some and shock, so very high dosage of norepinephrine plus vasopressin, 6 liters administered for fluid resuscitation. So. Fever, indeed. So it's septic shock from influenza, ARDS from influenza. And so they put the patient in a prone position. PF ratio deteriorated even more, so arrived to 45. So they called us, and we put him on ECMO. This is our standard femoral configuration. So femoral VV ECMO, but. This is what we usually do, but okay, any configuration of ECMO would have been, I think, reasonable. And this is the picture of the patient, and that's the chest X-ray immediately after ECMO connection. You can see, Ricard noted it, you can see the pulmonary artery catheter because we are a bit old-fashioned, so we use it. I know that Ricard doesn't, but anyway, that's our standard method of hemodynamic management.
So at this point, any caveat, any point you want to discuss about this case? Anyone? No?
I mean, I think that it's diagnosis is ARDS, indications for ECMO.
Was an echo done of the heart, the ejection fraction of the left ventricle?
The ejection fraction of the left ventricle, I have to tell you that I don't know, or at least I don't remember. Again, we monitor the patient with the pulmonary artery catheter since he had the norepinephrine and vasopressin before the probably it was mostly a vasoplegic shock. Then after we connected him on ECMO, as you can see here, we added norepinephrine decreased, but we added some epinephrine, so probably he had also some, let's say, cardiogenic contribution to the edema, but it's mostly, I would say, septic shock from ARDS, from influenza. Here it's cardiac output and the lactate levels that decreased from day 0 to day 1. We took bronchoalveolar lavage and blood cultures who were negative. So what would you do with the antibiotics in this patient? He was on piptazo and levofloxacin plus oseltamivir plus steroids. Would you continue the antibiotics? Would you stop them?
So the patient is a severe CAP with RDS. We have a positive test for influenza, but at this moment, we have so the empirical therapy includes antimicrobial, antibacterial, broad spectrum antibacterial antibiotic, but now you have BAL and blood cultures. So Giacomo's team stop antibiotic. Everybody agrees, or somebody is going to continue the therapy because it's severe CAP, RDS. Who will continue with broad spectrum antibiotics? Okay. So the rest, I guess, they will follow the strategy. You want to comment? You don't agree?
It's a viral pneumonia, influenza pneumonia. I would rather consider an ceftriaxone or ampicillin to de-escalate. I don't see the indication for an piptas here. Sorry, that's my opinion.
Yeah, no, well, we actually stopped all the antibiotics. You know that this is one point that we can discuss. So, first of all, now the guidelines say that we should not give antibiotics to a patient only because he is on ECMO, so prophylactic antibiotics are not recommended. If you start broad-spectrum antibiotics, like in this case, which is clearly reasonable because the patient has septic shock and we only had the positive influenza swab, so we could not rule out a bacterial superinfection. Then if you rule out the bacterial superinfection, actually there's probably no indication. So at least this is what we did. So we stopped the antibiotics, and of course we stopped also the steroids, which are in some way contraindicated in influenza, or at least while we continue with the antiviral drug.
So I understand both sides. So some of you decide this is in severe septic shock because the patient was in 2 vasopressors, hypoperfused, high lactate. So the cultures were taken, I guess, in your hospital, Giacomo. Yeah. We don't have the hospital of the cultures of the previous hospital. So those cultures were drawn with antibiotics. So many of you will think maybe there is a bacterial infection that then when arrived to Giacomo's hospital, the culture was negative because the patient was already in antibiotics. So I think both decisions are good. In this case, the escalation. Yeah,
we did it also because then we received also the culture from the previous hospital. So
both the decisions are, I think, are good.
Okay, so then you see that on day 3, indeed the patient actually improved. So you can see that compliance of the respiratory system increased. The intrapulmonary shunt fraction decreased from 45 to 30%, and we measure it with the pulmonary artery catheter. Lactates normalized, norepinephrine was almost stopped, epinephrine was stopped. No fever and no leukocytosis and normal, let's say, no signs of superinfection. So due to the improvement of the patient, we tried a trial of pressure support that failed, but okay, it was probably too early, but anyway, so we put him back to control ventilation, but we remained without antibiotics, no steroids, on oseltamivir, on ECMO, like this.
We are going to discuss this point later, but anyone wants to comment in CRP PCT levels? So we guess the patient is not infected, okay? I mean, influenza, but no bacterial infection. But the patient, day 3, the levels of PCT and CRP are going down, but still are high values.
Yeah,
You mentioned that the guy received methylprednisolone on day 1, so I would assume this is rather the effect of the corticosteroid than the recovery. Such a rapid drop in the CRP.
that's a possibility, maybe. I don't know.
The inflammatory response of ECMO may explain also some of this inflammation, just because the ECMO circuit. Yes, no? In part.
Yeah, maybe. Yeah. Anyway, then unfortunately the improvement stopped and the patient again deteriorated on day 7 and 8. You can see there compliance dropped again, shunt fraction increased, PaO2 decreased. We had to increase FiO2. Lactates were still within the normal ranges. Little bit of increase of norepinephrine, increase in white blood cell, and a trend towards an increase again in CRP, and a chest X-ray, which I don't know if you see it. Well, it's certainly not improved from the beginning. So my question is, what Ricard was saying, can we trust inflammatory biomarkers in patients on ECMO? Or is there an effect of the ECMO machine, the interaction between the blood and the artificial circuit that triggers the infection, the coagulation, activates coagulation and so on?
Who say that this is an infection and want to explain why? And who say that this is not an infection and want to explain why? We need 2 volunteers. Infection?
I don't say it's an infection, but it's already day 8 on intubated patient. So by day 8, it could be a VAP.
Yeah, it's very difficult to say. That's why we are here, actually.
But we can repeat the bell, or it can be also biological signs.
Which ones are supporting your guess?
The CRP is increasing. We have the white blood cells increasing.
How are the tracheal secretions?
The tracheal
I'll show you later
secretion.
because we have a picture of that. I can
We need to check them.
just to show you these slides. We're not going to comment it, but again, as Ricard was saying, the interaction between the blood and the artificial circuit anyway triggers the inflammation. This is what we know comes mostly from studies in cardiopulmonary bypass rather than on VV ECMO, but still there is an inflammatory reaction. So basically all the patients on ECMO, they tend to have high white blood cell counts, increase in CRP. Procalcitonin may be better, but it's not the perfect marker anyway. So the increase in the inflammatory mediators may still, I don't know, I don't have the coagulation markers there, so maybe that could be, let's say, an activation of the circuit. This could trigger again an inflammatory reaction. So I agree with you that anyway, this deserves further exam, and because the second question is, during ECMO, especially soon after ECMO connection, can we trust the chest X-ray? I mean, are you surprised that you put a patient on ECMO and then 1-2 days later, you see that the chest X-ray is worse than at the beginning? What?
Who wants to comment? Maybe you?
I think we didn't be very surprised by this. In case of worsening CT scan, after we start ECMO.
Why?
Because hyperinflammatory response from extracorporeal spores is present.
I think it may be the progression of ARDS, of the phase of the ARDS, and also the recruitment, because when you put on ECMO, you got still like low tidal ventilation, and the recruitment would worsen the lung consolidations.
Yes, I think we don't have the time to discuss this, but what we do, for example, in our center is that we decrease, of course, tidal volume, respiratory rate, and driving pressure. But we sometimes we even increase PEEP in order not to have a significant decrease in mean airway pressure, so to avoid the collapse of the lungs. But still, sometimes. And also, when you put oxygenated blood through the lungs, you lose in some part the hypoxic vasoconstriction. So sometimes you see a sort of, let's say, edema of the lung, which is due to the fact that some areas that were not very well perfused are again perfused because you increase SVO2. So the change in chest X-ray during ECMO, especially, this is a little bit late, I agree, but especially after the connection, sometimes are not, trustable too much. So what we did was just to answer Ricard's question, we repeated the BIL as it was suggested. And the BIL was positive for Klebsiella pneumoniae, very, very, I would say, very bad profile of resistance. So
what we want to discuss here for this case of BAP, now microbiologically demonstrated, is that you need a high level of suspicion because X-ray is not helping, fever is not helping, biomarkers are not helping. Secretions in this case was in the bronchoscopy, but sometimes you can see clinically that the patient is producing more purulent secretions, but need high level of suspicion. Okay, so you have to higher level of suspicion than in a patient that is not in ECMO because all these factors. So this is one point we want to stress in this case.
So it's carbapenem resistant Klebsiella. Well, I can tell you that this was a KPC as mechanism of resistance. I didn't put it here, which you can guess from the antibiogram. Okay, so we started meropenem, vaborbactam. There are other options. There are other reasonable options. Not, for example, ceftolozane tazobactam. It's not working against KPC, but ceftazidime avibactam could have been a reasonable option still, but meropenem probably has a better penetration in the lungs. So I don't know. Do you agree with this choice? Would you do something different? Do you have this drug? You don't have it? Because it's a new carbapenem, so protected carbapenem. So you agree? Would you have done something different or?
So we have little experience with merobarbo because in Spain we don't have so many KPC. We have much more OXA48, so we are going more for ceftazidime avibactam. But of course, if we have a KPC, for us merobarbo is a good option. The question is that in this patient, 2 days before, have a surveillance culture with. This is a respiratory sample, right?
Yeah.
A bronchoaspirate. So who is doing surveillance culture? 1 per week or 2 per week? Okay. And in this patient, how do you interpret these results on day 6? Will be a trigger for treating the patient, or you will wait until day 8? Very tricky to understand if the patient, this is just a colonization or an infection. So if you receive the results on day 6, in this very difficult patient, may be a trigger. So here to understand if it's this colonization or infection. In day 8, we have more symptoms.
But my comment was more that if you send the cultures on day 6, the results don't come back until day 8 in my hospital. So,
yeah, no, it's true. We're lucky. Now we have fast microbiology, so we have basically on the respiratory secretions, we have the results in a few hours, but
yeah, probably multiplex. You receive the same day 8, but the antibiogram.
Yeah, it takes.
Maybe you are relying in the antibiogram of the surveillance cultures. Okay.
Second point is this. This is important. Like the maximum temperature was 37.4, and again the same question: can we trust body temperature during ECMO?
Yeah, I have seen a fever of 40 centigrade Celsius in a patient on ECMO, but I would say this is rather exceptional that we have high fever on a patient with an ECMO and a heater cooler that controls the blood temperature.
What I can show you here is that some heaters Unfortunately, the new one that supplied us don't have this feature anymore. But anyway, the old heaters show you how many power you need to heat the blood. So usually it's between 40 and 70 watts. And sometimes you don't see changing the temperature, but the heater stops, which means that it doesn't need to heat the blood because the patient has fever. Okay, so the blood is, the temperature doesn't increase because the blood is out of the body, but still. So this is a sign that you can check. If you see that the heater stops heating, even if you don't see the temperature, you may guess that the patient is probably developing fever, at least.
Yes, and any other sign for the ones who have a lot of experience in ECMO, any other sign that we are missing here for the suspicion? So, tachycardia. What about? Go ahead.
No, you say the same. The heart ratio is more 118. There is 100, and then the saturation of oxygen is down. It's a little more down. Maybe the gasto cardíaco.
Cardiac output?
Cardiac output is more in this context, and then I need a little more of a system of ECMO.
So I have it here.
Maybe that.
So indeed, the patient developed some hemodynamic instability, so lactate started to increase again, 2.2. We had to increase norepinephrine, and cardiac output went up from 6.2 to 7.9, and indeed, we also increased a little bit the ECMO blood flow. So we have some degree of hemodynamic instability, and that's another point that I would like to stress with you, is that sometimes these patients, you have the idea that they are developing an infection because they become a little bit more unstable hemodynamically, even if you don't have, again, fever, or if you don't have an excessive increase on white blood cell or inflammatory markers. If at a certain point the patient becomes more vasodilated, cardiac output maybe is increased, he becomes tachycardic, and he was doing well, and so just because of the hemodynamic instability, always keep in mind that, it's an increase in the SOFA score, so it's also written in the guidelines to keep in mind that it can be triggered by an infection.
Another parameter that I've seen in ECMO patients with infection is not even a clinical parameter, but I realize, I noticed that some patients, we change the ratio of the flow of the heparin through the ECMO, the coagulopathy that they develop.
Yeah,
that's a very good point.
Yeah.
So anticoagulation remains unstable. Usually anticoagulation times increase. You should modify the dose of heparin, and also you can see sometimes fibrin in the circuit because the coagulation is active.
Yeah, we monitor. What we do in our center, that we monitor coagulation like 3 times per day, including the dimers, and once a day we monitor antithrombin 3. So sometimes you see consumption of antithrombin 3, increase in the dimers, and of course platelets and fibrinogen. So, but again, the activation of the circuit can be sometimes due to the fact that you are on ECMO for a prolonged period of time, and that at a certain point the circuit activates itself, or sometimes because you have sepsis that triggers the activation of coagulation. But it's true. Hemodynamic instability, activation of coagulation always should make you think that there might be something infectious behind. Other comments? Yes.
How was the venous saturation?
The venous saturation? Well, in this case, you see, the shunt fraction is 40%. We increase the blood flow it's still a good support because it's 4.3 liters per minute of extracorporeal blood flow over almost 8 liters of cardiac output. So I would expect, I don't have the number here, but if I had to guess, I would say like 88%, something like that, SVO2. But it's on ECMO, so SVO2, it's much better, if you want to know that, it's much better to measure the oxygen saturation of the blood that enters the oxygenator. So if you have a CardioHelp, for example, machine, or you can take a blood sample, it gives you the number of the oxygen saturation of the blood that enters the machine. Because actually the way how VV ECMO works is to increase mixed venous oxygen saturation. So it's very, very difficult to see very low SVO2 on ECMO unless you have an enormous oxygen consumption or the oxygenator who is failing. Because in this case, you can make the calculations, but the SVO2 would be the weighted average between the blood that returns to the heart and the blood and the saturation of that or the blood that enters the oxygenator. So you check that number. So if you want to know the real or a proxy of the mixed venous oxygen saturation of the patient, not influenced by the ECMO machine, you can measure oxygen saturation of the blood that enters the oxygenator.
Any other infection in this setting? I mean, we have BIP very clearly demonstrated, but patients with influenza in ECMO, previous septic shock, previous steroids, high level of suspicion of aspergillosis, okay? So high level of suspicion. So in this bronchoscopy, galactomannan and look for aspergillus. It's very important. Okay?
Would you measure also BDG in the blood?
Yes, but in this case, I think galactomannan in blood and BAL.
And indeed, he had bacteremia from Klebsiella pneumonia, more or less the same pattern of resistance that we saw before. And actually, we did this. This was decided by the infectious disease consultant. So I'm not responsible for this. But because if you remember, imipenem or relebactam was intermediate before. Now it's become, I don't know. Anyway, I'm sure that you can comment on this, but this is what we did. But
no, my concern here will be the dose. You know that imipenem relebactam is labeled for 500 milligrams, which for the lung and especially in ECMO, I will be very concerned about 500 milligrams of imipenem for treating this infection. So I will keep meropenem, better meropenem 2 grams. Mm-hmm. Both antibiotics are not absorbed by ECMO circuits, but again, it's an extra circuit, so the volume distribution is high, the patient is very sick, so I will go and have a resistant back. So I will go for meropenem 2 grams and not for imipenem 500 milligrams.
Why? Since this is bacteremic, would you add a second antibiotic, like for example, aminoglycosid?
No, no, I don't think so. And maybe as empirical therapy, we are very convinced that this is in the lung, it's bacteremic, but gram-positive coverage in ECMO. Are you doing prophylaxis in your patients for gram-positive? Okay.
We take the swab if they're. We try to decolonize them from MRSA, but we don't.
Somebody in the empirical therapy at gram-positive for suspicion of cannula infection? No. Okay.
I mean, that's a very good point. I mean, if the patient in this stage, I mean, you see that the patient is doing worse, he has increasing norepinephrine and so on, you take the blood cultures, but still probably until you have the results of the blood cultures, it's very reasonable to add an anti-gram-positive coverage empirically, because we see many superinfections from enterococci, for example, especially. I mean, we tend to be very careful, but you know, the femoral cannulas are.
This Klebsiella would have been susceptible to gentamicin and probably colistin. Would you consider SOD and SDD in
this is for you.
SOD as SDD as a treatment?
As prophylaxis for this PPM?
No. I mean, So SDD and SOD has been tested in scenarios with low level of resistance, not in levels in scenarios of high level of resistance in the Netherlands, and also not in this situation. So if the general policy of the ICU is to have SDD, I will do SDD in patients in ECMO, of course. But if it's not the general policy and for this specific setting, I will not. Maybe you can add inhaled colistin in this patient if you think that the bacterial burden in the lung is very high. This can be. I will not add additional intravenous antibiotics, but maybe can combine with inhaled colistin for a resistant microbe.
Who is using inhaled antibiotics? Yeah, personally, we tend to use it, but then our infectologists, they don't like it, so they always refrain us from using them. But I think that it's the problem with inhaled antibiotics is also then the cultures after that become a little bit less reliable, of course, at least the bacterial load, but we have done that. I mean, colistin, I wouldn't go with colistin IV. No. But inhaled, you can also have amikacin inhaled. So I mean, also aminoglycosid can be administered with a aerosol as aerosolized drugs. And this is just to tell you that it's very, very difficult to. We are now having a Delphi consensus on the diagnosis of cannula infection. So clearly, if you have clear signs of infection, purulent secretion from the cannula insertion site, it's easy. Otherwise, if you have in some patients with repeated blood cultures positive and you don't find this guy had a pulmonary source, but then to rule out the infection of the cannula or the oxygenator is very difficult in my experience. Only once I remember that when we are really desperate, I mean desperate, we changed the cannulas. So, but that was like because we really didn't know what to do. But it's possible that the oxygenator and the cannulas become colonized from the germ. But again, it's difficult to there are studies with CT scan of the oxygenator, studies of differential bacterial load before and after the oxygenator, but it's very difficult to say that the oxygenator is the source of the infection in a patient. I think that
this slide is nice because this is what is the previous one. This is what is recommended to have transparent dressing. Can you come back one slide?
Oh, yes, sorry.
Yeah. So to have transparent dressing, to be able to check the insertion point, you have to keep it. I mean, we change it every week, but we can look if there are infection, if there are local infection. If there is local sign, then you have to take the swab. Okay.
And also, another thing very important is to review the policy of, for example, change of the venous lines, because it's not recommended to change them too frequently. So, and also again, as Ricard was saying, the dressing. So, but it's very important to check on the patient every day, to visit the patient. I know that now everyone likes the echo, but still the clinical visit is important and sometimes. So this was just to tell you that that's a paper that we published, but that we do surveillance cultures, and we are able to recognize which patients become colonized, and those patients who are colonized have a higher risk of developing an infection from the colonizing germ, but we don't treat colonization. So we use it as a, let's say, hint to understand which germ we should tailor the treatment in case the patient becomes septic, because we know that the patient is colonized from an MDR germ. So, but we don't treat colonization, and I don't know, but I think that this is, and okay, this case had a happy end anyway, despite the unwise choice of the antibiotic. Any other final comment? Yes, because I think we are.
Yes, going back to the first few days of the patient, you never considered stopping steroids because of having an influenza virus?
We stopped it.
Ah,
I
right.
told you, yeah, we stopped the steroids, and we are. I have to say that we are quite reluctant to use steroids. Probably in ARDS, probably we are wrong, at least for some patients. But for sure, with influenza, we don't give steroids. Then, yeah. No one else after this.
Yes.
In relation about the infection in veno-venous ECMO, in your practice, do you use beta blockers to reduce the cardiac output of the patient?
So this is a difficult question. We are not using beta. I mean, in the ECMO setting, I have no experience.
Yeah.
Outside of the ECMO setting, you can use beta blockers for 4 reasons. 1, to reduce heart rate, increase systolic volume, increase cardiac output. Second one, to reduce inflammation, because beta blockers are able to modulate the inflammatory response. Third one is to prevent or to treat tachyarrhythmias that may happen in the setting of infection. Yeah, those are the 3 main reasons. By now the data is not supporting those indications, despite there is some rationale of that, especially recently with the short-acting beta blockers, landiolol, esmolol, the trials were negative. And they are saying that if there is a tachyarrhythmia, using an ultra-short beta blocker helps to control the heart rate and to stabilize the patient, but not as a therapy for treating non-compensatory tachycardia, reduced heart rate, etc.
Yeah, to me, this
I don't know if there is a specific information in ECMO patients, but this is the general information.
Well, on this I agree. I mean, I think that we need to understand whether tachycardia is due to a hyperadrenergic state or if it's a compensatory tachycardia, because, I mean, in these patients, our goal is to increase the oxygen delivery. And so, I mean, sometimes, I mean, having norepinephrine plus a beta blocker is a bit of a nonsense. In ECMO, someone has proposed the use of beta blockers to reduce cardiac output of the patient in order to increase the ratio between extracorporeal blood flow and cardiac output. But I mean, it's a little bit like when you freeze the patient so that for the same PaO2 you see a better oxygen saturation, but it means that you had the tissues can extract less oxygen. So, to me, I wouldn't do that, because if you do that, then you will decrease the SVO2 of the patient very, very much. So, and in the end, you will decrease the oxygen delivery to the tissues. So we never do that. I mean, but
The next one is when
maybe you can increase sedation. Maybe you can again maybe try to control temperature within normal ranges, but not manipulate cardiac output. But there are reports in ECMO. I think that we are out of.
Yeah, we have exceeded our time. If there are no more questions, I think we are going to close here. Thank you for your active participation.